All right, welcome to The Explainer. Today, we're jumping right into a really tough clinical scenario, one that can trip up even the most experienced doctors out there. We're talking about the stiff heart of restrictive cardiomyopathy.
So picture this. You've got a patient in front of you with all the classic signs of heart failure. They're short of breath, they've got edema, but then the echo report lands on your desk, and it says the pump, the systolic function, is totally fine. It's squeezing just like it should. This is that classic, puzzling picture of heart failure with a preserved ejection fraction, and today we are going to crack this case wide open.
Okay, so here's how we're going to break it all down. We'll start with the puzzle itself, introduce our main culprit, go through the diagnostic workup, check out the lookalikes, talk management, and then wrap up with a toolkit you can actually use.
So let's get right to the heart of the matter. This isn't your typical heart failure where the pump is weak. The problem isn't the squeeze. It's not a systolic issue. Nope. The real problem is with relaxing and filling. It's a diastolic problem. The ventricle has become so stiff that it just can't fill up with blood properly. And when that happens, where does the blood go? It backs up. And that's what gives you all those classic congestive symptoms.
And that right there leads us to our prime suspect, restrictive cardiomyopathy, or RCM for short. That's the formal name for it. It's really a disease defined by this severe diastolic dysfunction. You've got these stiff, non-compliant ventricles that just physically cannot accept the blood that's trying to get in.
Okay, but why? What's actually happening deep down to cause all this stiffness? We're talking at the cellular, even the genetic level, and it turns out the story is a lot more interesting than you might think.
So if you were to zoom way in, down to the microscopic level, what you'd see is this patchy scarring or fibrosis and just general chaos, myocyte disarray. That mess is what robs the ventricle of its ability to stretch and fill. But here's the really fascinating part. We're now discovering that RCM is often tied to the very same gene mutations in sarcomeric proteins that cause hypertrophic cardiomyopathy. HCM? It kind of makes you wonder, right? Could these two diseases just be different faces of the same underlying genetic problem?
All right, time to play detective. You've got RCM on your list of suspects. So how do you actually build the case? What are the key pieces of evidence you need to look for to nail the diagnosis?
Your number one tool, without a doubt, is the echo. And what you're looking for is a very specific, kind of strange combination of findings. You're going to see these huge blown-out atria, a direct result of those crazy high filling pressures. And you'll see evidence of severe diastolic dysfunction. But, and this is the absolute key, the ventricles themselves, normal size, normal wall thickness, and a normal ejection fraction. When you see that pattern, RCM should be screaming at you from the top of your differential diagnosis.
So the workup itself is pretty logical. You always start with the echo. If things are still a bit fuzzy after that, a cardiac MRI can be a huge help, especially for sorting out what's what. And, for those really tricky cases where you're just not sure, an endomyocardial biopsy might be what you need to get that final, definitive answer.
Okay, let's pause here, because this next part is maybe the most important thing we'll talk about today. RECM has these doppelgangers, these mimics that can look almost exactly the same. And getting this differential diagnosis right, it is absolutely critical for your patient. The stakes are really high. And the number one mimic you have to worry about is constrictive pericarditis. So why is this so important? Well, think about it. For RCM, we don't really have a cure. But for constrictive pericarditis, there's a potential cure: surgery, a pericardiectomy. So if you get this wrong, the implications are massive. So let's break down the key differences. With RCM, the problem is in the heart muscle itself. It's stiff. With constriction, the muscle is fine. It's being squeezed from the outside by a rigid pericardium. A great clue is the BMP level. It's usually sky high in RCM, but surprisingly low in constriction. And the absolute hallmark of constriction is something called ventricular interdependence. It's this idea that because both ventricles are trapped in this rigid sac, when one fills, it pushes on the other. You just don't get that with RCM.
Now, the other big one on your list should be cardiac amyloidosis. That's another disease that infiltrates the heart and makes it stiff. But here, the echo gives you a fantastic clue. Remember how RCM has normal wall thickness? Well, amyloidosis almost always causes increased wall thickness. That one little detail can be a huge giveaway and point you down the right path.
Okay, so you've nailed the diagnosis. Now what? Well, this is where it gets really tough. There's no magic bullet for RCM, no specific therapy to fix the underlying problem. So management is all about controlling symptoms, and let me tell you, it is a very, very delicate balancing act. The biggest challenge by far is managing their fluid status. I mean, your patient is drowning in fluid, so your instinct is to hit them with loop diuretics to help them breathe. But here's the catch-22. These stiff hearts are super dependent on having enough fluid or preload to fill up. They need high filling pressures just to keep their cardiac output up. So if you pull off too much fluid, their blood pressure tanks, their kidneys take a hit, and you can actually make them worse. It's a real tightrope walk.
And then there's atrial fibrillation. It's super common in these patients, and it's a total disaster when it happens. Think about it. You lose that atrial kick that helps shove blood into the stiff ventricle, and the fast heart rate means there's even less time to fill. It is a perfect storm for hemodynamic collapse, so you have to be aggressive. Rate control and anticoagulation are non-negotiable, and you should probably be thinking about a rhythm control strategy pretty early on.
And we have to be honest about the prognosis here. It's not good. This is a very serious diagnosis. The 10-year mortality rate is around 63%. That's pretty sobering. It really drives home just how important careful management is and why, for some patients, we need to be thinking about advanced options like cardiac transplantation.
Okay, let's wrap this up. I want to boil everything down to the absolute essentials, the stuff you can take with you on your next shift. This is your RCM clinical toolkit.
Here it is, your mental checklist. Patient has heart failure, but the echo shows massive atria, terrible diastolic function, yet a totally normal-looking ventricle in terms of size and squeeze. Your brain should immediately go to RCM, and your very next thought, like a split second later, has to be, could this be constrictive pericarditis? Then you go hunting for clues. Check that BMP. Look for ventricular interdependence. I can't say it enough. Getting that distinction right changes everything.
And that leaves us with a really exciting question for the future. You know, this whole discovery that RCM and HCM share some of the same genetic machinery, that's huge. It's like finding out two totally different looking puzzles are actually made from the same pieces. So you have to ask, could this genetic link be the key? Could it unlock a whole new era of therapies that don't just treat the symptoms, but actually target the root cause of these diseases? It's definitely something to think about, and a little bit of hope to end on.